welcome to this lecture on eczema. So, what do we mean by eczema? Eczema is a word that comes from the Greek language, and what does it mean in the Greek language? It means to boil. Literally, the skin here boils. So, what exactly it is? It is described as a condition where there is inflammation of the skin. So, the skin is inflamed, it is red, there are vesicles, boils on the skin, there is oozing of inflammatory fluid. That is what was meant in the olden times by the boiling of skin. So, what do we gain from it? We know that this is a reaction pattern of skin. Why does inflammation happen? Inflammation happens because of the reaction. Reaction pattern could be due to any irritant, allergen, a disease, or any other environmental factor which is disrupting the normal homeostasis of the skin. Now, coming to the morphological classification, eczema, how it looks like, that is the morphology of the rash, decides its classification into three parts. What is that? Number 1, acute eczema. Number 2, subacute eczema. And the third, chronic eczema. So, depending upon how the rash looks like, you divide it into acute, subacute and chronic eczema. Now, what is the thing about acute eczema that you need to see? Look at the image here. What do you make out in the image? You see that there's a lot of redness here. There are some fluid-filled vesicles. There's even a bulla here. So, acute eczema, like the name suggests, is acute. It's immediate, acute in onset, acute looking. There's redness, there's vesicles, there's a lot of oozing of this inflammatory fluid. And if I do a histopath from this acute looking rash which is angry, actually the word for acute eczema is angry looking rash. So, if I do a histopath from this angry looking skin, what will I find? I will find that my skin is full of fluid. Yes, there's a lot of inflammatory edema within the epidermis. So, where does that fluid come? There are cells which are tightly packed in the entire epidermis. If there has to be a fluid in the epidermis, where will it come? It will come in between the cells. What will be the picture on histopath? There will be intraepidermal, intercellular edema. So, what do we mean by intraepidermal? We know this is within the epidermis. Intercellular means it is between the keratinocytes, and edema means there is a fluid accumulation. So, there is a lot of fluid accumulation within the epidermis in between the cells. How does it look like? It looks like this image. You see these empty spaces between the cells? These empty spaces look like a sponge. Okay, these empty spaces look like the holes in the sponge, which is why the histopath picture of acute eczema is also known as spongiosis. So, the histopath picture of acute eczema is also known as spongiosis. Coming to the subacute eczema, what do you see in subacute eczema? Subacute, as the name suggests, the intensity has reduced, the rash has settled down in severity, So what I get here is subacute eczema. So from the acute redness, now it is reddish brown. The inflammatory edema has settled, the vesicles have settled, and the rash has now started to develop scaling. So it will be a reddish brown rash with some scaling and some oozing. So it will be lesser in severity as compared to the acute rash, reddish brown in color, more of scaling and less of oozing. Coming to the third one, which was chronic eczema. So chronic, as the name suggests, is an eczema which has been there since a long time. So this is a chronic duration of the rash. What are the special findings that I see in a chronic rash? The special findings, look at the image here. What do you see? You see that one, it is hyperpigmented as compared to the surrounding skin, right? It is hyperpigmented. Then look at these lines here. These lines. Follow my pen. Look at these lines. Is such a line visible on a normal looking skin? No. In an acute rash, was it visible? No. Look at your hand and find these skin lines on the hand. Do you see any of these? Neither on your hand, nor on your wrist or anywhere. So these lines are more than normal. That means there are exaggerated skin markings. So the skin is hyperpigmented, there are exaggerated skin markings, and if I try to pinch the skin, I will find that this is thickened. So there is thickening of the skin in the rash. So these are the three findings which I see in the image of a chronic eczematous rash. What is this together called as? Together, these findings are known as lichenification. So when we say that there is a chronic eczema, we say it is a lichenified rash. Look at some old people around you who've had an itchy condition for a very long time. So when they have an itchy condition for a very long time, that is when they develop such a morphology of the rash. This is known as lichenification. Why am I stressing upon it so much? Because this is a very important question with respect to the exams. Very important. What do they ask you here? They ask you these three components of lichenification. This could be there in the all except form. All of these are the findings in lichenification except. In the PGI, it could be a multiple choice question. So you need to remember these three components of a lichenified rash. Another way to remember it is this. Lichenification has three things increasing. So there is an increase, increase and increase. What? The first increase is increase in color of the skin, that is, it is hyperpigmented, increased lines on the skin and increased thickness. So these three things that increase together form the three components of lichenification. If I take a skin biopsy from this rash, what will I find? A skin biopsy, that is the histopath examination of a skin biopsy from a chronic rash, is going to yield this. What is acanthosis? We have repeatedly discussed acanthosis. It is the increase in thickness of stratum spinosum. So this is increase in thickness of stratum spinosum. This is the hallmark of the histopath of lichenification. Again, this is an important question. The way spongiosis was important for acute eczema, acanthosis is important for chronic lichenified eczema. Coming on to the etiological classification of eczema. Etiology, what does etiology mean? Etiology means cause. So depending on what is causing the rash, we divide eczema into two categories. Which is the first category? Exogenous eczema. And the next one is endogenous eczema. So exogenous, you can very well know from the name of it. Exo means outside. So here the cause of the rash is outside the body. So there is some reason which is otherwise outside the body, but when it comes into contact, it causes a rash. In cases of endogenous eczema, the cause comes from inside the body. So there is a endogenous cause to the eczema. How do we know whether an eczema is endogenous or exogenous? By studying it, by taking a proper history, clinical examination, and finding out what falls under what. Now, there are three types of eczemas that come under endogenous eczema. What are these? Under the exogenous, we have three types: contact dermatitis, phytodermatitis, and photodermatitis. Okay, so contact dermatitis, phyto and photo. Now you tell me, what is the meaning of contact dermatitis? Something touches the skin, it causes a rash at the site of the contact. What is phytodermatitis? Here the cause phyto means plant. So here the cause is a plant. Photo, what is photo? Photo is sun. So here the cause of the rash is sun. So all these three external stimuli, when they cause eczema, it is exogenous eczema. Under endogenous, the most important one under endogenous eczema is atopic dermatitis. So this is amongst the most common endogenous eczemas. Then we have Pityriasis alba, Pompholyx, and seborrheic dermatitis. So these are the important endogenous eczemas. They are also just asked as a routine, which of these is an endogenous eczema, which of these is an exogenous eczema. The questions mainly focus upon the endogenous when they are just broad base of the question. Okay, so which of these is an endogenous eczema? So you have to remember these ones: atopic dermatitis, Pityriasis alba, Pompholyx, and seborrheic dermatitis. So coming to the first category, that was exogenous eczema. Under exogenous, the first one that we study is contact dermatitis. So what is contact dermatitis? Contact dermatitis, as the name suggests, is a reaction pattern of skin to substances which come in contact with the skin. Very self-descriptory, this line, it's a reaction pattern of skin to some substances which come in contact with the skin. So that is what you get from this term. Contact is touch, dermatitis is the rash. So anything that touches the skin, like in this image, it could be a deodorant, it could be some detergent, some medicines, some plants, whichever come in contact with the skin, they may cause a rash. So that is contact dermatitis. Now, depending upon the kind of rash that develops, the duration, the mechanism, we divide contact dermatitis into two parts. So this depends upon the mechanism of the rash. The first part here is irritant contact dermatitis, and the second type is allergic contact dermatitis. Okay, so this is dependent upon the mechanism of the rash. Starting with the first one. Now, what is irritant contact dermatitis? ICD in short we call it. ICD, that is the short form. So, how does irritant contact dermatitis develop? This develops due to, as the name suggests, irritant means something is troubling me. There is no reason why it is troubling me, but I am getting irritated, I am getting troubled. So here it develops just due to the substance itself, like whether it is toxic, it is vesicant, whatever is the mechanism of the substance in itself, that is going to cause the rash on the skin. There is not much science behind it. It will just come, rest on my skin, cause the rash then and there. So this develops within a very short period of time. So between the contact to the rash, it is a very small amount of time that has passed. What is the mechanism of the inflammation? The inflammation here happens because of involvement of the innate immunity. The Langerhans cells, like in this image here, there is this irritant. This irritant enters the skin. The Langerhans cells, which are the first point of contact, part of the innate immunity, they take up the antigen. There is some digestion that happens here, and immediately you have these inflammatory cells coming into the skin. There is no lag period, there is no time wasted. Moment irritant comes, taken up by Langerhans cells, inflammatory cells come in, cause the rash. So that is irritant contact dermatitis. So coming to allergic contact dermatitis. Now, how is it different from irritant contact dermatitis? Here, the substance that is coming in contact with the skin acts like an antigen. So here, this acts like an antigen. What is the meaning of antigen? Antigen is something that elicits an immune response. So this antigen is going to come in contact with the Langerhans cells. After that, it is going to travel to the lymph nodes, greet everyone, have a gala time, elicit T cells, elicit memory T cells. Okay, so here it is just meeting all my immune cells, just introducing itself to them and telling them that hello, I exist. So what is this phase? You've read this in pathology. This is called as the sensitization phase. And where do you see the sensitization phase? You see this in the delayed type 4 hypersensitivity reaction. So What does this antigen here do? This antigen elicits a delayed type 4 hypersensitivity response. So this is what this antigen is going to do here. And now my body is ready for it. It doesn't like it. Even though it was greeting it fine, it doesn't like it. So on the second exposure or the subsequent exposure, it is going to show what it is. So it is going to send these memory T cells immediately to the skin, cause an inflammation there in order to remove this antigen. So here the rash develops in subsequent exposures, not in the first one. Why? Because in the first exposure, it is only sensitizing. In the subsequent exposures, it is eliciting its reaction, that is the true wicked form of my skin. Look at this diagram here. Look at this diagram. Here, the first exposure antigen is only sensitizing. In the second exposure, it is eliciting the immune response. This travels to the lymph nodes, causes specific T cell generation, and these specific T cells on the second exposure travel back to the skin, cause signs of inflammation to happen, and thus the allergic contact dermatitis happens. This is much in contrast to the irritant contact dermatitis, where it was the first exposure, the substance was acting like an irritant. So it was acting like an irritant with its own specific toxicity coming into the skin, causing the rash then and there, not involving any specific immune response. So this difference is very essential to understand. So irritant contact dermatitis versus allergic contact dermatitis. This is just another table that is showing you what it is. Irritant causes irritation. It's a non-specific immune response involving only the innate immunity. Whereas in allergic contact dermatitis, the substance is acting like an allergen, eliciting type 4. Please note, type 4 immune response involving specific adaptive immunity and thus causing the inflammation in the skin. Okay? Repetition of the same point is, here the inflammation is induced by the toxicity of the chemical. Here the inflammation is induced by the activated T cells. So with that, we now come to some important causes of each of them. Starting with the irritant contact dermatitis, the most common cause, a very important question in itself, the most common cause for irritant contact dermatitis is detergents. Detergents are the most common cause of irritant contact dermatitis. Okay, who uses these detergents the most? Look at around you. Detergents are used for washing utensils, for washing clothes, for cleaning. So who does this cleaning? Housewives. So majority of the housewives do it, which is why this is also called as housewife dermatitis. So because of the detergent, it is also known as housewife dermatitis. You get a question, housewife dermatitis is a type of irritant contact, allergic contact, etc., etc. So you have to know that the housewife dermatitis is a type of irritant contact dermatitis. Now, whenever something causes ICD, how does the morphology look like? Here the morphology can look like acute rash also, like I use a detergent for the first time, I get an acute VP rash. But if I keep using the detergent for a very long time, I can also have a chronic picture of rash. So it is not necessary that an acute irritant dermatitis is always going to look very angry, very red. Over a cumulative period of time, it may also look like the chronic lichenified rash. However, the pathomechanism of ICD remains the same. Now, what is the second most common cause? The second most common cause here is alkalis and solvents which are used in the rubber industry, the textile industry. All of these people use a lot of alkalis and solvents. So there also irritant contact dermatitis is an important occupational dermatosis. Coming to the third most important cause. What do you see in front of you? Yes, I have written it. This is diaper dermatitis. But what you see in the image, you see that this is the groin area of a female baby and there is an erythematous rash over this area. So why does this diaper dermatitis develop? This diaper dermatitis develops because of the irritant action of the components present in the urine, especially ammonia, then stool, that is the feces. When the baby passes the feces in the diaper, it gets smeared on the skin, and the irritants present in such a urine and stool come in contact with the skin, facilitated by moisture and maceration. When there is moisture, the skin becomes hydrated, more porous to these outside substances. So facilitated by the moisture and maceration of a closed space, these components lead to an irritant contact dermatitis. So diaper dermatitis, also called as napkin rash, is a type of ICD. What are the components that are causing ICD? It is the urine and the stool along with the moisture, and sometimes it may be some component of the diaper also. So maybe the diaper is also not suiting the baby. How does it look like? What are the clinical features? Generally happens after keeping a soggy diaper for a long time. That is, the mother doesn't change the diaper as often as it is supposed to be. So that soggy, moist diaper full of urine and stool stays in a longer contact with the skin. Then there is some episode of diarrhea. In diarrhea, the irritant potential of the stool is higher, then the baby may be taking some medicines that may also irritate the skin when they come out with the feces. So when there is episode of diarrhea or a soggy diaper for a very long time, that can lead to an erythematous, oozy, acute rash. So erythematous, oozy, acute rash. What are the sites? The sites, as you notice in the image here, it is involving here, here, here. What is it sparing? It is sparing these sites. So these sites are spared. What is involved? The convexities are involved while the creases are spared. So the convexities are involved, the creases are spared. Why? Because it is the convexities, that is the bulges, which come in maximum contact with the irritants and not the creases. That is a way we clinically diagnose diaper dermatitis. Okay? Moving on to the next cause. The next cause is Piedra dermatitis. So what exactly is Piedra dermatitis? This is a kind of insect bite reaction. So this happens due to an insect bite reaction. It is due to the bite of the blister beetle. So it is the blister beetle insect which is causing Piedra dermatitis. This insect is in high amount of population during the rainy period. So you get a lot of cases of insect bite reaction during the rainy period. What does this cause? When the beetle is on the skin, it releases a toxin in its saliva or feces that is known as piedrin. Okay, this toxin is known as piedrin. This is a very strong irritant, and when it comes in contact with skin, it causes irritant contact dermatitis. So you may also get these erythematous, vesiculopustular rash in a linear pattern. Why do you get it in a linear pattern? Look at the image here. You see that the rash is going linearly. Why? Because the way the insect travels on the body, it is going to produce the rash in the similar distribution. Okay, so this is the rash in the linear pattern, which is why it is also known as dermatitis linearis. So if you get such an image in the exam, you should know that this could be an insect bite reaction, which is a type of ICD. The insect is blister beetle. So this is the insect here, blister beetle. Name of the toxin, piedrin. Type of rash, ICD. Presents in a linear pattern. And a question on this will also mention this history, that there is history of sudden overnight onset. Means the patient slept fine, when they woke up they had this rash. So the insect is a nocturnal insect, generally comes out in the night, causes the rash. So you sleep well, but in the morning you wake up to such a rash. So this is Piedra dermatitis. Moving on to allergic contact dermatitis. Now allergic contact dermatitis, I told you and I will repeat here, it is a type of type 4 hypersensitivity reaction, which is the delayed type hypersensitivity. It happens on second or subsequent exposures, and there is involvement of the adaptive immunity here. All these points are very important. Now, what are the substances that commonly cause allergic contact dermatitis? The most common metal cause of ACD, ACD is short for allergic contact dermatitis, in India is, look at the image here. Can you take a hint which is the most common metal cause? Where is this happening in this image? It is happening at the site of wearing a ring. Here, this is happening at the site of a neck piece. And in the last image, it is at the site of contact with the belly button of the jeans. So, any common thing that you notice? What I notice here is that wherever there is a metal coating on the jewelry, on the buckle, you may get it on the wrist where the strap metal touches. So all these sites where this silverish coated substance of the metal jewelry is touching, there you get this rash. What is the most common part of that coating? The most common part of that coating is nickel. So the most common metal cause of ACD in India is nickel. In a question, it may be mentioned that an erythematous itchy rash develops at the site of wearing a artificial metal ring. The rash develops at the site of wearing a metallic earring, a metallic bangle, chain. When in clothes, it could be in the button on the belly. It could be where the belt buckle touches. So it is not just the belly button of the jeans. It can also be where the buckle of the belt touches. So whenever such a hint is given in the question, always think of nickel as the potential answer there. Coming to the dermatitis which is seen in laborers, a question may mention a history of occupation like a cement worker, a laborer. Okay, so cement worker, laborer, sometimes even this word is written, mason. Mason means somebody who works with cement and bricks. Same as this, same as this. So do not get confused by the word mason. A mason, 45-year-old, comes to you with a 1-year history of an itchy, dry, lichenified rash on the hands and the feet. What is the causative agent? So if the word mason is written, I get this hint that this person has an occupational contact with cement. Cement is a known cause of allergic contact dermatitis. But what in cement? In cement, it is potassium dichromate. Very, very important, dichromate. Sometimes in your question, it may be written as chromate. No, it is not chromate. It is dichromate. So keep this in mind. Di is a word which you have to remember along with chromate. Dichromate. Look at the image here. You have this rash which is erythematous, too brown, dry and scaly. That means it's a chronic eczema. Means the patient has been working for a long time with that antigen, causing a chronic dry lichenified rash. So this is cement dermatitis, cause for which is potassium dichromate. Coming to hair dye dermatitis. What is the cause of hair dye dermatitis? We have different types of hair dye in our country. The natural vegetable hair dyes, the synthetic hair dyes. So when we talk about hair dye, we divide that into a natural, vegetable hair dye and synthetic hair dye which contains chemicals. Maximum amount of chemicals in a synthetic hair dye are in the permanent type of hair color. There are temporary, semi-permanent, permanent, but the maximum amount of chemical is needed in the permanent hair dye because that is where you need to alter the hair shaft maximum so that the color goes and settles there for a long time. Okay, so maximum amount of chemicals are in the permanent. That is why I have just written this. When we talk about vegetable hair dye, the most common vegetable hair dye used in India is henna. Henna means mehendi. All of you must have heard about this. That is mehendi. What is the particle here? It comes from the plant called as Lawsonia. And what is the color here? Color is provided by a chemical called as lawson. So Lawsonia is the name of the plant. The color here is lawson and it gives a very nice orange brown color to the hair when it is natural henna. But if you combine henna with some other chemicals like PPD, then it is called as black henna, which in the market is known as Kali Mehendi. So when it is Kali Mehendi, black henna, then you know that it has added synthetic hair dyes. But a mehendi which gives orange brown color, you know it is natural henna, that is Lawsonia. Now coming to the permanent hair dye, because these are the dyes which actually cause the rash. Natural hair dyes are very low allergic potential. They are very healthy for the hair and the skin, do not cause any rash. But whenever they are contaminated with these industrial chemicals, or if you use an actual synthetic hair dye, that is when there is a chance of a dermatitis developing. Now, which is the most important component of hair dye that causes a rash? Yes, you know it. It is PPD. What is the full form of PPD? Paraphenyl diamine. So this is P, P and D. So PPD, paraphenyl diamine. There is another chemical, it can also be asked in the question, that is PTD, para-toluene diamine. These are the most common antigens present in the hair dye that cause dermatitis, and the most common type of dermatitis is allergic contact dermatitis. The most common type of dermatitis caused by the hair dye is allergic contact dermatitis. But point to be noticed for the PGI type of questions. For the PGI type of questions, hair dye can cause not only allergic, it can also cause irritant contact dermatitis. It can also cause contact urticaria. There could be a lot of manifestations, ACD, ICD, contact urticaria, etc. So if you get a question in the PGI, that is a multiple choice question, then all these three can be marked. But in a multiple choice question where only one option is asked, then the most common mechanism of causing the rash is allergic contact dermatitis. I hope you have followed this. When there is a single option, it is ACD, but in case of a multiple option question, it can be both ACD and ICD. And how will the question give the clinical features? The clinical features here, as you see in this image here and here, is that you get an acute rash on the scalp and face, neck. So any area where the hair dye chemicals, they can come, like they come on my neck, they come on my face, the preauricular, postauricular, the anterior neck, the posterior neck, everywhere that chemical can touch, it can cause a dermatitic rash. So this is about hair dye dermatitis. Most important chemical, PPD. Coming to Bindi dermatitis. Yes, Bindi dermatitis. This is a unique kind of dermatitis seen in the Indian women. Why? Because traditionally they put on a bindi. Now bindi is not harmful. What is harmful is the adhesive on the back of the bindi. So if that adhesive is not of good quality, it will contain some chemicals. What are the chemicals? The chemical here of interest is PTBP. So what was the name of the chemical? PTBP. Now what is PP? Not PB, it's PTBP. What is this? This is para-tertiary butyl phenol. So para-tertiary butyl phenol is the chemical found in the bindi adhesive that causes a allergic contact dermatitis. Okay, so this is the chemical in the bindi. It is also a question here, right? Now there is one more thing that comes here, which is the most common topical medicine to cause ACD. The most common topical medicine to cause ACD is neomycin. So the most common chemical ACD to cause such a rash is neomycin. So we'll just revise the most commons again. What is the most common cause of ACD in India? We'll be discussing it in the next slide. But overall, most common cause of ACD in India is Parthenium. Most common metal cause, nickel. Most common topical medicine is neomycin. Most common cause of ICD is detergent. So these are just some most common which you need to remember here. Coming to the next part, which talks about phytodermatitis. What is the meaning of phyto? Phyto means plant. So this is a plant which is causing a rash. Now what is this plant? Do you see the image here? This kind of a weed with small white flowers you must have seen at a lot of places. It can grow anywhere and everywhere, rural area, urban area, anywhere it gets a bit of soil, it can grow. So what is this weed? This weed is called as Parthenium hysterophorus. What is this weed called as? This weed is called as Parthenium hysterophorus, also called as Congress weed. Now you must be knowing, you must have read this for your pre-medical exams also. Congress weed is another name for Parthenium hysterophorus. This is the most common cause of plant dermatitis and most common cause of allergic contact dermatitis overall. Okay, so these are the two most commons for which the answer is Parthenium hysterophorus. What is the antigen here? In other words, also the allergen. So what is the allergen? The allergen here is present in the plant leaves and the stem, sometimes even in the pollens of the flowers. So what is the name of this? This is SQL. In short, SQL. Now what is the full form of this SQL? Full form of SQL is Ses Quitter Pen Lactones. So what is the full form? Ses Quitter Pen Lactones. So Ses Quitter Pen Lactone. SQL is the name of the allergen in this plant which causes the rash. Now, how does it cause the rash? What is the mode of contact with the skin? This plant has this sesquiterpene lactone which goes into the air. So this spreads the allergen into the air, and with the air it will come and settle on the skin. So within the air is flowing, I am out in the open, the allergen is going to come and settle on my skin. So what will this be? This will be the reason why we have another name for this, which is airborne contact dermatitis. So this is the reason why Parthenium dermatitis is also called as airborne contact dermatitis, because the allergen from the plant is going to travel onto my skin from air. Where will it settle? Obviously, the sites of the rash will be the exposed areas of the body. Which is the exposed area? The first area to be involved is the face. So, first area to be involved is the face. Which is the most exposed area on the face? The periorbital area. So, it is the periorbital area which is going to be the most, the earliest site involved in this rash. After this, you are going to see the rash on the hands, on the feet, and dependent upon the amount of clothing worn in that area, you may get a rash sometimes up to the upper arm, sometimes till here if sleeveless clothes are worn. So, the site of the rash depends upon the amount of clothes worn and thus the amount of body exposed. What will be the morphology of the rash? It is going to be mostly a subacute to chronic. So, it will be reddish brown. As you can see on the hands here, it is going to be reddish brown, dry, scaly eczema. If it is for a long duration, it may also give this chronic lichenified rash. So, depending upon the duration, you may even get this. Which will be the typical patient? The typical patient will be a person living in the rural area or a farmer, because that is where the weeds are in the highest concentration. What will be the patient? It will be a rural farmer coming with an itchy, dry, scaly rash on these sites. How do I diagnose? It is mostly a diagnosis based upon clinical history and examination. But what if I am not sure? If I am not sure, I have a confirmative or a definitive diagnosis using a modality known as patch test. So, the modality for diagnosis that I use here is patch test. We will discuss it in detail when we come to it. Just one more point here. How will you treat this farmer? Number one is cessation of exposure. I will tell them to change their environment. Come and stay somewhere else for a little time, or you stay indoors, don't go outdoors, don't go to the farms where the weeds are present. Secondly, steroids. My drug of choice is going to be steroids, given both as cream or ointment as well as oral steroids. So, the drug of choice here is steroids. But if the patient is a known case of diabetes mellitus, hypertension, or has developed some side effects of steroids, what is going to be my agent of choice? In that case, my drug of choice is going to be azathioprine. So, in that case, the drug of choice, in case my patient is an uncontrolled diabetic, uncontrolled hypertensive, has cataract, or has developed some Cushingoid side effects of the steroids, what is the other drug that I can give? The other drug that I give here is azathioprine. This has been asked in questions. If it's just a simple question, there is steroid in the option, that is the answer. But if the question gives you any such history, then you should know that they are trying to elicit this answer of azathioprine. And another common question asked with ABCD is patch test. How do you make a definitive diagnosis? By using a patch test. Coming to photodermatitis. So, what is photodermatitis? As the name suggests, photo means sun, dermatitis means rash. So, this is a sun-induced rash. Now, how does sun induce a rash? Light is not causing the rash here. This is not just a light-induced dermatosis. This is a photoallergic or a photoirritant dermatitis. So what does this mean? That there is this substance, when it touches the skin, it needs sun to activate it. And when that sun activates it, it either behaves as an irritant or as an allergen, thereby causing the photocontact dermatitis. Is this clear to everyone? This is how you have photocontact dermatitis. What are the common causes? Common causes are antibiotics, like the sulfa antibiotics, then another antibiotic that comes here is sparfloxacin and tetracyclines. Very important causes are sulfa drugs, sparfloxacin and tetracyclines. All of these have been individually asked in questions. Another cause, NSAIDs, especially the oxycam group, that is your COX, especially the oxycam like piroxicam and other COX-2 inhibitors. Then, what are the other causes? Psoralenes, retinoids and sunscreens in themselves. Questions have been asked on the sulfa drugs, sparfloxacin, tetracyclines, the oxycam group of drugs, psoralenes and retinoids. So these have already been asked as causes of photo drug reactions. So please remember them. So how do we make a diagnosis of contact dermatitis, whether it is irritant, allergic? How will we make a diagnosis? Yes, definitely clinical history and clinical examination I will do, right? I will take history, but can I ever be very sure? No. How do I make a definitive confirmed diagnosis? A definitive confirmed diagnosis is by this route, patch test. So it is this patch test which allows me to confirm the antigen or allergen responsible for the contact dermatitis, thereby allowing me to make a definitive diagnosis of allergic contact dermatitis. If the question says ABCD, then ABCD also, because airborne contact dermatitis is also a type of allergic contact dermatitis. And there is another use. It allows me to differentiate between allergic contact dermatitis and irritant contact dermatitis. If you ask me for the purpose of your questions, this is the most important and this is the most important. Okay, so what allows you to differentiate between allergic contact dermatitis and irritant contact dermatitis? It is patch test. So, what is patch test? What is the method? In the method, we have these strips which contain fin chambers. I'm just writing this word in case it is mentioned in any question. Fin chambers, these are the aluminium chambers, these ones, which you see on this strip. In these aluminium chambers, we pour the antigen, we put it on the back, and then we check for a rash. This is as simple as I can put it. I have this PPD antigen. I have isolated it because I know the patient has come to me with a hair dye dermatitis. So I have to confirm if PPD is the cause. I take a ready-made synthetic PPD formulation, put it in this chamber, stick it on the back, read it after 48 hours and see if the similar erythematous rash appears there or not. So that is how I will make a definitive diagnosis, which is why I say that this will allow me to confirm the antigen responsible for the rash. Now, what is the principle on which patch test works? The principle on which it works is again type 4 hypersensitivity. This also works on delayed type hypersensitivity response. If I am exposed to the antigen, I already contain memory T cells. If I stick the antigen on my back, the memory T cells will give rise to more affected T cells. They will come to my back, cause the rash. So the principle for this is similar to the allergic contact dermatitis. It is also going to work on the same principle. Which is the site? It has been asked in one question, what is the site of the patch test? The site where I put the patch test is upper back, as you can also see in the image here. So the principle and the site are two important points here. Now, how do I interpret it? After putting the strip on the back, when do I read? The reading of patch test is done at 48 hours. So 48 hours after I put the strip, I call the patient, remove the strip and look for the rash. So the reading of patch test is done at 48 hours. However, if your question will ask this, the best reading taken, the best reading is taken at 96 hours. So the patch test, if you have to read it on a routine basis, it is 48 hours, but the best reading it as 96 hours. This was asked in the AIMS exam this November, when is patch test read? So they had options with different 48, 56, 48, 96, 24, 48. The option that we had to choose in the AIMS exam was 48 hours and 96 hours. They had both these terms. So you not only have to remember 48, you also have to remember 96. Now, how do you read it? What to see? You see whether a rash has developed at the site. Then what is the morphology of the rash? Whether it looks like ICD or ACD. So this will allow me to differentiate whether it is ICD or ACD. Okay. So these are the different points about patch test which you need to remember. Most important is the reading. Like in this image here, patch test is positive here, here and here. In case of ICD, there will be a sharp cutoff, means it will be a completely round rash, while in ACD, it can disseminate. So around this round rash, it may be a non-uniform kind of a picture. So that is how on examination we know whether it is an irritant contact dermatitis or contact allergic dermatitis. Now there has been one more question with respect to patch test, that is on photo patch test. Here what we do? Here we do the patch test in duplicate. So we put duplicate strips on the back. After 48 hours, we expose one strip to UVA light. So we expose one strip to UVA light, and 96 hours later we read the test. Okay, so we put patch test in duplicate. After 48 hours, expose it to UVA light, read it at 96 hours. If the site where the sun or the UV light was exposed, only that is positive, that means it's a photoallergic dermatitis. If both the sites are positive, then that means there was no role of sun, positive on both sides. And if both are negative, there is no photoallergic dermatitis. Okay, coming to the treatment of contact dermatitis. Number 1 is cessation of exposure to the trigger. Number 2, topical management. Topical we do with steroids. Then oral management. Oral again for severe diseases, steroids. Then azathioprine and cyclosporin. These are the 3 drugs that can be used for oral management of contact dermatitis. So now, after doing the exogenous eczemas, we now move on to the endogenous eczema. As I already told you in the initial part of the lecture, endogenous eczema has an internal systemic cause to it. The first endogenous eczema that we study here is atopic dermatitis. So what exactly is atopic dermatitis? I just told you that this is an endogenous eczema. How do we define this? This is a chronic relapsing remitting, means it has a waxing waning course inflammatory condition of the skin. So this is a chronic relapsing remitting inflammatory condition of the skin. This is called as atopic dermatitis. Now, what is the meaning of atopic here? Atopic means allergic. That means in this atopic dermatitis, there is increased tendencies for allergies in the skin. It could be reacting to that particle which a normal person may not react. So somebody who has a genetic tendency is predisposed to develop atopic dermatitis, develops an allergic rash to an antigen which is otherwise not causing that rash in me. So this is allergic dermatitis, where the skin has an unusually excessive allergic response to normal substances. So what exactly is the etiopathogenesis of atopic dermatitis? So what are the components that are causing this problem in the skin? What are these components? Starting with the first one and the most important, because without this it can't happen: genetic factors. Number 2, defective skin barrier. Number 3, immune disbalance or immune abnormalities. And number 4, even though this is an endogenous eczema, it still requires some environmental factors to cause it. So these are the 4 important components of etiopathogenesis of atopic dermatitis: genetic factors, defective skin barrier, immune abnormalities, compounded by some environmental factors which come and cause the disease. Starting with the first one, genetic factors. What are the genetic factors that are important here? Here, the factors could either be in the skin genes or they could be in the immunity genes. So, immunity genes or skin genes. Which is that gene in the skin which is important here? Here, it is the FLG gene on chromosome 1. So, it is the FLG gene on chromosome 1 which is the most important genetic factor associated with atopic dermatitis. What does it code for? This codes for a protein called as filaggrin. You have read this in the first topic where we discussed keratinization. I told you that filaggrin is a very important protein meant to continue keratinization in a normal way. This is known as a filament. This is known as a filament aggregating protein released from the keratohyalin granules of stratum granulosum during keratinization. So this makes this cell which is going to enter the stratum corneum a compact small cell by aggregating all the cytoskeletal filaments of the cell. So it is very important to aggregate these, make it into compact cells so that the corneocytes can arrange properly in the stratum corneum, thereby forming the impermeable barrier of the skin. So filaggrin gene is very important to maintain a proper skin barrier. What are the immune genes that are involved here? The immune genes are also called as atopic genes. That means this gives that susceptibility, that tendency to the body to react allergically to common substances. These are the genes which are mostly coding for interleukin 4 and 13, which are involved with IgE and the eosinophils. So this gives a atopic tendency to the body when the interleukin 4 and interleukin 13 are dysregulated. Coming to the skin barrier, the second point that I told you is that the skin barrier is defective. The stratum corneum corneocytes are supposed to be arranged in this manner. This is the normal manner in which they are supposed to be arranged. But in case of an atopic skin, there is a problem up there. So when there is a problem up there, the allergen can travel to the deeper part of the skin and meet the Langerhans cells, go to the lymph nodes, elicit an immune response. So your allergens and infections go deeper into the skin, elicit an immune response, thereby causing inflammation. So defective skin barrier is extremely important component of the etiopathogenesis of atopic dermatitis. Why is this barrier defective? Number one, there are decreased lipids in the skin. These lipids are the sterols. When these lipids are reduced, you have a dry skin, and dry skin is irregular and provides easy entry to the allergens and the infections. Secondly, the filaggrin is defective. So if filaggrin is defective, your corneocyte barrier is also defective. So these are the two reasons why your skin barrier is not functioning properly in an atopic patient. Third thing that I told you is immune disbalance. In the immune disbalance, the most important part is that interleukin 4, 5 and 13, which regulate eosinophilic inflammation, are on the higher side. So number one, there is increased interleukin 4 and 13 in these patients. Secondly, there is a Th2 dominant immune response. In normal people, the Th1 dominant immune response is present. So that doesn't have much tendency to atopic. In atopic dermatitis patients, it is the Th2 dominant immune response. So there is an increased tendency to have allergies. And number 3 is that there is excessive IgE response. So there is an excessive IgE response to normal allergens. If I were to react in an X manner, an AD patient would react in a 10X manner. Excessive IgE response, which leads to a lot of histamine from the mast cell, which causes a lot of itching also. So that is also another reason for a lot of itching in this rash. The fourth factor that I told you was the environmental factors. Here, the points of importance are number 1, the dust mites. Then number 2, you have infections. And number 3, some environmental factors like what is the season, whether it is dry season of winters or a humid season of summers. Then what is the level of humidity in the air. If there is decreased amount of humidity, you have a tendency to have dry skin, which increases atopic dermatitis. Similarly, in winters also you have a dry skin, so winters will increase atopic dermatitis. The disease is more severe in winters. Fourthly, you have some other allergens like food, pollens, etc., which have increased tendency of causing ED in people. Now, what are the clinical features? When we talk about clinical features, the first thing that we will discuss here are the clinical phases of the disease. Phases of the disease mean at what point of life is it coming, or is it continuing from that initial point in life? Where exactly do you see the patient? In which stage of the rash? That is why we have it in division of 3 phases. The 3 phases here are number 1, the infantile atopic dermatitis. Number 2, childhood atopic dermatitis. And number 3 is adult atopic dermatitis. Okay. So these are the 3 phases in which we see a patient of AD. What is the age group? Infantile phase generally develops during the birth to the 2-year age period. This one is 2-year onwards till puberty, while that phase which is there post puberty is the adult atopic dermatitis. Going to the infantile AD. The infantile AD, as I just told you, the age is 0 to 2 years. What is the morphology of the rash here? The morphology of the rash is an acute rash. What was that acute rash? It was the red vesicular oozy rash. The sites most commonly on the face and the scalp of the baby. As I show in the image here, this is the face and this is the scalp. You see this red vesicular oozy rash here, a very typical acute AD rash. This is very all important for the images also. Such an image is commonly asked in the question when they talk about infantile AD. So you get these lesions on the face which are red oozy. These ones have a certain degree of sparing. They spare the periorbital and the perioral area. So the perioral and the periorbital area is spared and the convexities are involved. So this is about infantile AD. As the child starts crawling, so when the child starts crawling, imagine a baby crawling. Which site of body will come in contact with the environment, the allergens? It is going to be this arm, the legs, the thighs. So these extensors of the body will be the first points of contact of the baby's skin to the environmental allergens. That is why, starting from the face and the scalp, the next point of the rash is the extensors. So infantile AD has an extensor distribution of the rash when the baby starts crawling. That is beyond the age of 1 year up to 2 years. It is the extensors of the body that are involved. What happens when the baby grows onto the childhood? So 2 years to puberty is the time when they have this kind of a morphology. What is the morphology of the rash here? This is more of an subacute type of eczema. So it is going to be this reddish brown scaly rash with some oozing. So this is the morphology of childhood AD. What are the sites? What do you see in the image? In the image, you see that it is the flexures that I have shown here. Why? Because this is a time of transition. Here, the rash is moving from the extensor to the flexure. So predominantly, you see a flexural pattern here, although there is a transition also happening. Why does it move to the flexures? Because now the child is moving around in the environment. He's going to a park, he's going to a mall, he's going everywhere. So the allergens in the air, in the clothes, they will settle more in the creases. The creases have sweat, there is hydration of skin, more porous to allergens. Therefore, there is an increased tendency of rash in the flexures. So gradually from the extensor, it is moving to the flexures. Which is the most common flexure that is involved? The most common flexure involved is the cubital fossa. So the most common flexure involved here is the cubital fossa. What happens when the patient grows up? When they grow up, they go into the adult AD. So what is the age for this adult AD? The age for this is beyond puberty. What is the type or morphology of the rash which we see here? The morphology of the rash is more of a chronic lichenified eczema. So a chronic lichenified eczema is what you see in a patient of AD. What was lichenification? Increased color, increased lines and increased thickness of the skin. What do you see in this image here? So there is a hyperpigmentation of the skin. There is increased skin markings. If I pinch it, I find it to be thickened. So this is a chronic lichenified eczema. The sites, again, this is a predominantly flexural eczema. So even a question which is talking about adult AD will write this word. This will be written in a question which talks about adult AD. Flexural eczema is seen in the patient. Why have I put this diagram here? I've put this diagram because this shows some coin-shaped lesion. So the most common shape of the lesions in atopic dermatitis is a discoid shape. So it is discoid eczema that is the most common morphology of the rash seen in AD. Even this has been asked in a question. So remember that the most common type of rash that you see here is a discoid rash. Now coming to the diagnostic criteria. I have seen the patient. Now I want to make a diagnosis. As you see in the criteria here, these are all clinical criteria. So the diagnosis of AD, there is even a question on this. The diagnosis of AD is purely a clinical diagnosis. There is no need of any lab test to make this diagnosis. So this is purely a clinical diagnosis. We have diagnostic criteria. What is the name of these diagnostic criteria? These are called as Hanifin and Rajka criteria. So what is the name of these criteria? Hanifin and Rajka criteria. It contains 4 major and 22 minor criteria. But we don't need to remember the criteria. We just need to remember some important points in those criteria. So what are the main points here? Number first is pruritus. So patient must have pruritus along with the typical morphology and distribution of rash, a chronic episodic dermatitis, along with a history of atopic diseases. So these are the 4 major criteria which are required for making a diagnosis of atopic dermatitis. You need only 3, but most of the patients that we see have all of these criteria. Discussing just a few points here, pruritus. This is the most essential criteria for atopic dermatitis. Rather, this is the hallmark of AD. It is histamine mediated. The pruritus here is histamine mediated. And what is the type of itching that you see? You see an intermittent, means it happens at some points in the day and is very severe. So you have an intermittent, intense pruritus. Such severe pruritus that I cannot make a diagnosis of atopic dermatitis without itching. I cannot. It is the most essential criteria. Sometimes what happens is that the patient is itching, that there a rash develops after the itching. So this is why it is also called as, AD is also called as a itch that rashes. So it is also called as itch that rashes because the patient is itching so much that a rash develops due to the itching. The scratching, the repeated scratching causes a lot of defect in the skin barrier, further introduces allergens, causes a rash there. So itch that rashes. Now there is also a question which says itch is a disease, refers to. So there is just this one line in the question, itch is a disease, it refers to atopic dermatitis, seborrheic dermatitis, contact dermatitis, pityriasis alba. What is the answer? Answer is atopic dermatitis. So itch is a disease also refers to atopic dermatitis. Then what was the second criteria? Second criteria was typical morphology and distribution. This, depending upon which phase you are seeing the patient, it's infantile, childhood or adult, that is when you decide the typical morphology and the distribution of the rash. Third is chronic relapsing remitting. Patient says, I have the rash in winters, it decreases in summers. I sometimes have it again in the summers, but it reduces, then it increases. So it has a waxing, waning course. And the fourth criteria, personal or family history of an atopic disease. What is that? It is this. The patient may have one or the other components of the atopic triad. Atopic, as I already told you, means a tendency to develop allergy. So a patient who has eczema, that is skin allergy, may have tendency to develop allergies in the lower respiratory tract in the form of asthma, may give history of using an inhaler, or may give history of recurrent sneezing and colds, that is hay fever, which is also called as allergic rhinitis. So there may be a history of atopic diseases of the upper respiratory tract. Now, interestingly, here the family history may be there or personal history may be there. The criteria also mentions both, either personal history or family history, because there is a genetic tendency of atopic genes. So even in the family, if I get a history, I can use that. Family history or atopic history. What can be given in the question? Recurrent, cold, sneezes, wheezing sound, or using inhalers. Then there may be history of chronic urticaria. There may be history of food allergy. That is, there may be history of diarrhea, abdominal pain on eating either peanuts or seafood. So some questions may even give you this history, that the patient has an itchy eczematous rash in the flexures. He also gives history of having abdominal pain and cramping on eating shrimps or fish. What is the diagnosis? A baby has an red erythematous rash on the face and the scalp. The mother gives history of bronchial asthma. What is the diagnosis? So you may be given either a personal history or a family history of atopy as a hint in the question. Now, what are the other clinical features? There are some other clinical features which are also possible questions. First one is lip-lick cheilitis. The patients have dry lips, so they tend to lick it with their tongue, because of which there is an inflammation of the lips known as cheilitis. Typical picture, you see that the rash is extending a bit beyond the lips. That is, till the point the tongue reaches, you have the rash. Now these patients have red lips plus a perioral pallor. That's also a minor criteria, but it is there, a perioral pallor and red lips. So just imagine this red lips surrounded by perioral pallor. What does this look like? This looks like the headlight of a car, which is why it is also known as the headlight sign. So this is also known as the headlight sign. Important question seen in atopic dermatitis. The next thing that we see here is the Hartog's sign. Now what is Hartog's sign? Look at the image here. You see that there is a loss of eyebrows in the, there is a loss of hair in the lateral eyebrows. So there is a loss of hair in the lateral eyebrows, which we call as madarosis, commonly seen in leprosy, myxedema, atopic dermatitis. When madarosis is present in atopic dermatitis, it is called as Hartog sign. Again, this is an important question. The next finding that you see is xerosis. I already told you that the lipids are reduced, the skin is dry, so patients of AD tend to have xerosis. Fourth point, keratosis pilaris. Now, what is keratosis pilaris? Keratosis pilaris is, as the name suggests, follicular papules. Pilaris means hair, keratosis means a skin papule. So follicular papules on the extensor surfaces of the arms, thighs, upper arm, thigh, upper back. So these are follicular papules. Why do they develop? In a patient of AD, the hair coil like this. So when they coil, they are twisted, skin forms an inflammatory rash around the hair. So you see these coiled hair, when you see them closely, you see this coiled hair and a papule around it. This is known as keratosis pilaris. And you look at them tangentially, you see that a lot of hair are coming out vertically from the skin like this. This is why it is also called as the antenna sign. These look like the antennas of the old time, those zigzag antennas, which is why it is also called as antenna sign. Another question that comes on the signs in atopic dermatitis. What else? We see this white dermographism. So what is white dermographism? White means white, dermo means skin, graphism means writing on the skin. So you have a white mark on the skin when you write it. So wherever you stroke the skin with a blunt object like the nib of a pen or the back of a pen, you get white lines. Why does this happen? This happens because of intense vasoconstriction, which is an abnormal response in atopic skin. So why does white dermographism happen? It happens because of intense vasoconstriction in the skin. So when it vasoconstricts, it blanches, which is why it looks pale white. So this is white dermographism. Important question here. With dermographism, there are 3 points. Dermographism means marks on the skin. Red dermographism is seen in physical urticarias. White dermographism is seen in atopic dermatitis, and black dermographism is seen in nickel dermatitis. So just remember these different colors: red dermographism, white and black, out of which questions have been asked on red and white, but it can always be there on the black dermographism also. Then these patients have a tendency for increased lines on the palms and soles. So they have an increased crisscrossing lines on the palms and soles. Some periocular signs, most important, Denny Morgan fold. What is Denny Morgan fold? These are extra lines below the eyes. That means these are extra lines in the infraorbital area. Very important. Remember, where are these seen? They are seen in atopic dermatitis. Then you also have a type of keratoconjunctivitis here. What is the type of keratoconjunctivitis? You have papillary keratoconjunctivitis affecting the papillary part of the conjunctiva. You have these cobblestoning papules. That's a question from ophthalmology. Cobblestoning papules seen in papillary keratoconjunctivitis, more common in atopic patients. Then what do you see in the image here? You see that the cornea is conical. What is this called as? Keratoconus. Kerato means cornea, conus means conical. So there is an anterior coning of the cornea, which is called as anterior keratoconus, seen in atopic dermatitis patients. Again, this is a question. Then anterior subcapsular cataract. When we talk about subcapsular cataract, it can be anterior or posterior. This one is the anterior subcapsular cataract, also called as shield cataract. Also called as shield cataract, very classical of atopic dermatitis. And where do you see posterior subcapsular cataract? That is a side effect of long-term oral steroids. So that's a side effect of long-term oral steroids. Now coming to the treatment of atopic dermatitis. How do I treat this patient? Number one is general measures. General measures is avoid dry skin, use plenty of emollients and moisturizers. So use plenty of emollients and moisturizers. Then we come to medical management. In medical management, we have topical drugs. What are the topical drugs? Number one, steroids. Number two, TCIs. Now, what are steroids and TCIs? TCI is topical calcineurin inhibitor. What are the topical calcineurin inhibitors? Topical calcineurin inhibitors are tacrolimus. So what is a topical calcineurin inhibitor used in atopic dermatitis? Tacrolimus. It is an important question. It is a immunomodulator. It is not an immunosuppressive. This is an immunomodulator, while steroid here works as an immunosuppressive. In what formulation will I give steroids? When I give steroids in AD, in acute AD, I will give it in the form of a cream, and in chronic AD, I will give it in the form of an ointment. So this will be how I will decide my formulation, because ointments are more greasy. They will make the dry skin also better, while cream I will give on acute VP rash, because there it is not going to obstruct the oozing. Coming to oral management. In the oral management, we have oral steroids, oral azathioprine, and oral cyclosporin. So these are the three drugs that I can give in a patient of atopic dermatitis. Now there are some new drugs. These new drugs are, one is given orally, the other is given topically. So which is the new oral drug? It is Dupilumab, and topically it is Crisaborole. See, this is systemic. Sorry, it is given in the form of injections, not oral. Dupilumab is an anti-interleukin 4. The interleukin which we discussed was in high concentration in atopic dermatitis, and crisaborole is a phosphodiesterase 4 inhibitor. This is given in the form of a cream. So these are the new drugs that are used in atopic dermatitis. While Dupilumab was approved in 2018 for moderate to severe atopic dermatitis, crisaborole was approved for mild to moderate atopic dermatitis. So also remember that dupilumab was approved for moderate to severe AD, while crisaborole was approved for mild to moderate AD. So with this, we finish atopic dermatitis. And now coming to the next endogenous eczema, that is seborrheic dermatitis. So what is seborrheic dermatitis? As the name suggests, this is a rash which is affecting the seborrheic, that is the oily sides of the skin. Now, why do we have seborrheic dermatitis? We have it because there is an inflammatory reaction to a commensal yeast living in the sebaceous glands. What is the name of this commensal yeast? The name of this commensal yeast is Malassezia furfur, also called as Pityrosporum ovale. P. ovale was the old name, now it is Malassezia. If a question says Malassezia, then that will be your best answer as a cause for seborrheic dermatitis. Coming back to the sites, which is the site? So what are the seborrheic sites of the body? Seborrheic sites of the body are the face and the scalp, then the upper back, upper chest, and the axillae and the groins. So these are the seborrheic sites of the body. They will have increased predisposition to seborrheic dermatitis. Now, where on face and scalp? Let us see where this boy gets atopic dermatitis. This boy is going to get seborrheic dermatitis. One, his luscious hair are going to be full of dandruff in the scalp. Let's make it white. Right? He's going to have a lot of dandruff in the scalp here, and then he's going to have this yellow greasy rash in the glabular area, the ali of the nose, nasolabial folds, mental crease, preauricular area, and the postauricular area. So these are the seborrheic sites on the face. What will be the age of the patient who gets seborrheic dermatitis? Since seborrheic dermatitis is due to sebaceous glands. When are the sebaceous glands more active? In an infant, when the maternal androgens have stimulated them, or in the teenage, when the puberty androgens are stimulating the sebaceous glands, and sometimes due to an unknown reason in the elderly. So these are the three age groups where you get a seborrheic dermatitis. When it happens in the infants, there is a special form to it which we will discuss. It is also called as cradle cap. So infantile seborrheic dermatitis on the scalp is also called as cradle cap. Now, if a patient is developing seborrheic dermatitis at any other point in life, what will be the reasons? The reasons could be number one, either he is suffering from HIV or Parkinson's disease. So these are the two reasons for acquired seborrheic dermatitis. They are asked in the exam. There have been questions talking about HIV and Parkinson's as causes for acquired seborrheic dermatitis. What are the clinical features? How does this rash look like? So the main clinical feature here is an erythematous rash in seborrheic sites. What are the seborrheic sites? As I just told you in the previous slide, ali of the nose, nasolabial, mental area or the mental crease, glabular complex, post-auricular, scalp. So these are all the seborrheic sites of the face and the scalp. But just having a erythematous rash in the seborrheic sites is not sufficient. What else do you need? You need a yellowish, greasy scale. So the yellowish, greasy scale that you see in the image here, see the yellowish, greasy scale, this one. This yellowish, greasy scale here also you see, this is the classic finding that you have in seborrheic dermatitis. Very important, any question that's talking about SD will tell you that it has a yellowish, greasy scale. Now just talking about treatment, like any other eczema, you will give steroids in seborrheic dermatitis, but there is also a role of antifungals here. Why? Because you have malassezia as a cause. So there is also a role of antifungal shampoos or creams when you treat seborrheic dermatitis. Now, infantile SD, as I told you, cradle cap. What is cradle cap? Cradle cap is infantile seborrheic dermatitis of the scalp seen in babies. Classic feature, again, this yellow, greasy scale. The next eczema that we talk about here is pityriasis alba. What is pityriasis alba? Where does this fall into? A very important question related to it is endogenous eczema. Age group, seen generally in children. Any association? It is associated with the history of atopy. What are the clinical features? These will be multiple hypopigmented macules with fine scaling. What will be the course of the disease? It will have an episodic course. Lesions may come and go. Treatment, moisturizers and a mild steroid. So let us just go through this again. Important points. Endogenous eczema. Patient will be a child. They will have multiple hypopigmented macules with fine scaling. Look at the image here. See this child, this lesion, this lesion, this. There are these multiple faint color or hypopigmented macules with fine scaling. Most important point is fine scaling. Have an episodic course. There is a question on pityriasis alba which mentions that these lesions come and go on the skin of the child. So if there is a hint that these are episodic, you know they are talking about pityriasis alba. Treatment, moisturizers and mild steroids. Now, what is important here? When there is a hypopigmented macule on the face of a child in a question, what do you have to focus upon? You have to focus upon two differentials. What are the two differentials? P alba and indeterminate Hansen's. We have already read this in the lecture on Hansen's, how to differentiate between P alba and this. P alba will be in a child. This will also be in a child. There may be a history of atopy. Here, there will be history of coming from an endemic zone of leprosy like Bihar, Chhattisgarh, Jharkhand, Eastern Uttar Pradesh. So the residence of the child may be mentioned as one of these states. Then this will be multiple lesions. This will be a solitary lesion. Fine scaling, no scaling. This will have an episodic course. This will self-heal and not come again. So these are just some differences. Yeah, that's how you see. These are just some differences that you see between P. alba and indeterminate Hansen's, which allow you to choose the right answer in your MCQ. The next endogenous eczema is Pompholyx. I have already said this, but I will also write it. This is also a type of endogenous eczema. What are the sites? The sites are the palms and soles. How does it look like? You have multiple tense, deep-seated vesicles. So you have these, look at this closely, multiple tense, deep-seated, fluid-filled lesions in the palms and soles, which are intensely itchy. Points to notice: vesicles, intensely itchy. Is there any other feature? Yes, it is also known as the sago grain appearance. These multiple tense, deep-seated vesicles look like sabudana. Sabudana, have you seen those round white balls, the sabudana? These sabudana are in English called as sago, and these deep-seated vesicles look like those sago balls kept on the palm. So this is the sago grain appearance, a very important question also asked in the exam. Sago grain appearance is seen in, so it is seen in Pompholyx. Treatment is steroids. What is the next eczema here? Next eczema is nomular eczema. Nothing much to remember here. You just have to know that this is also called as discoid eczema. What is discoid eczema? See these round rashes? These are the coin-shaped eczematous rash that you see. It is just a morphological entity that says it is coin-shaped. Where is it seen? Generally seen in middle-aged men. Site is also asked as a question, lower leg. So just remember the image here. This is an image of the shin. So the rash is most common on the lower leg, seen in middle-aged men. Coin-shaped discoid eczema, also known as nomular eczema. The next rash that we have here is varicose eczema. Where is this seen? This is seen in patients with long-standing varicose veins. This is also called as stasis eczema. This happens because of vascular damage to the skin due to venous pooling of blood. When the blood pools in the veins, it compresses upon the surrounding small capillaries which provide blood to the skin. When such a thing happens, there is some amount of inflammation happening around. A lot of WBCs come out of these blood vessels, go into the skin. There they induce inflammation, cause a rash. It is known as varicose eczema. It cannot be treated in the absence of treatment for varicose veins. So if a patient has varicose eczema, initiate treatment for varicose veins and alongside give steroids for this rash. The last topic in the endogenous eczemas is asteatotic eczema. Now that's a new name that we have read. We haven't really read asteatotic anywhere. So what does asteatotic mean? A is for no, steer is for fat, eczema is the rash. So this is a rash that develops in the elderly population because of intense dryness due to decreased lipids in the skin. So when there is a defective barrier due to the dryness, there is an increased tendency for developing a rash, and that rash seen on the lower leg of these elderly is known as asteatotic eczema. Look at the rash here, it's along the creases. The skin breaks along these creases. This is why it is also called as a crazy pavement sign. It looks like that pavement on the road. And due to these cracks, there is another name for it. It is also called as eczema crackle. So an eczema where there are cracks in the skin. What you have to remember here? You have to remember that this is seen in the elderly because of decreased fat. Most common site is lower leg, has two other names to it, crazy pavement sign and eczema crackle. So with this, we finish the lecture on eczema.